Hello, everyone. Welcome to Offbeat Medicine. If you guys can hear me, please write in the chat box that you can hear me. And also, if you could drop down your name or where you're coming from, that would be great. And we're just going to get started. Great. Awesome. Okay, awesome. Let's get started. Okay, now we're going to talk about multiple endocrine neoplasias, men. One of the good mnemonic is men are dominant. So they're all of these men 1, 2A, 2B, all of them are going to be autosomal dominant inheritance. Simple, right? But most importantly, we got to know which men includes what. For that, we have a very nice picture here. Okay, so let's take a look at this first, and then we will read what the book has to say. So first thing we have is men 1. It has 3 P's. In those 3 P's, we're getting something from top, which is pituitary, 1 from pancreas, and 1 is parathyroid, right? 70%. Now, importantly, in men 1, 90% of the patients will for surely have this parathyroid adenoma or hyperplasia, 90%. And pituitary adenoma is about 70%, all right, of these men 1 patients specifically. Now, if you look at men 2, it has 2 P's and 1 M. So just remember, men 2A does not have any physical findings, no physical findings. And that's going to come high yield when we talk about men 2B. Okay. Men 2A, no physical findings. 2B, yes, physical findings are there. Okay. So men 2A, what do we have? We have 2 P's now: parathyroid, pheochromocytomas, and medullary thyroid carcinoma. Now, importantly, which ones occur first here? So high yield point is going to be your medullary thyroid carcinoma occurs first, and then you have pheochromocytoma, which is the adrenal medulla tumor, right? So, and now when I talked about no physical findings, you got to know it because when you compare it with men 2B, all men 2B has is it's going to be 1 P's and 2 M's, and that 1 P is your pheochromocytoma, and 2 M's are your again medullary thyroid carcinoma and mucosal neuromas. Now, high yield for this guy for men 2B is going to be for your physical findings that in these patients they have. First of all, look at this picture of mucosal neuromas here also. Mucosal neuromas. Now, on top of mucosal neuromas, they're also going to have another M called marfanoid habitus. Okay, they will have marfanoid appearance, and we will talk about it when we go into details, which is also mentioned in here. But what I want you to know here is simple thing, and we will talk about the whole thing, and there's a good mnemonic. Actually, let's talk about the mnemonic first here. Okay, all we want to do is, okay, we have men 1, right? Men 1, you are going to think about 3 P's. 3 P's. Those 3 P's are going to be, first of all, from top, you got the pituitary, and then you have the pancreas. These are 2 P's, right? Third P, you're just going to put in the middle like this, parathyroid. And with Men 2, you are going to think of two things. Men 2, both of them will have specifically both of these two things, which are your, again, the pheochromocytoma. I'm just going to write pheo, and medullary carcinoma of thyroid. Okay. These two, men 2, no matter A, B, both have these two, right? Now with an A, you just go up top, which was the parathyroid, you just include that one with A. With the B, you include those physical findings that we talked about. Physical findings, for example, let's just put them here as well. We have mucosal neuromas, and the marfanoid hepatus. Okay, so this is going to be pretty much what we have for this, and let's just read it and then move on. This is what you got to know this. It looks simple, but if you know it, it's worth it. Okay, with that, let's move on and let's read this now. Okay, men 1, we talked about it. We have a pituitary tumor. Pituitary tumor most commonly secretes prolactin or growth hormone that you know already. Now, the pancreatic endocrine tumors could also be the pancreatic endocrine ZE syndrome, Zollinger-Ellison syndrome, insulinomas, lipomas, glucagonomas are rare. Anything. When you talk about pancreatic endocrine tumor, any endocrine part of the pancreas can go into tumor. Parathyroid adenoma, not only adenoma, but you will see, it will be seen as hyperplasia of the parathyroid gland. Okay, that's also seen. And how is this going to present? Again, it's going to present with increased calcium. Simple. They might not even mention all of this, the parathyroid adenoma, hyperplasia, but they will mention with association with increase in calcium, and that will cause recurrent kidney stones. A patient coming in with recurrent kidney stone and has some sort of other thing, you are going to think about parathyroid adenoma associated with men 1. Okay, with that, you have to know, okay, there is a mutation in men 1. What is men 1 anyways? That's the tumor suppressor, which codes for menin, right? Which is chromosome 11. 1 is 11, but not high yield. Just to know, okay, men 1, menin, chromosome 11. Other than that, you can have angio associated with angiofibromas, cholangiomas, and meningiomas, not high yield. Move on to M2A. 2A, these are all going to be your medullary tumors, right? Medullary tumors, in which, if you think about it, parathyroid is also parathyroid hyperplasia, medullary, and adrenal medulla, right? Which is pheochromocytoma. So 2 medullary and 1 parathyroid hyperplasia. With that, let's talk about each one of this. You have medullary thyroid carcinoma, which is a neoplasm of a parafollicular C cells. They won't mention this, right? Well, what are they going to mention? Hypocalcemia. If they're mentioning this parathyroid with hypercalcemia, so they will mention medullary thyroid carcinoma, which is a parafollicular C cells, which secrete calcitonin. So they will mention this with low calcium. So low hypocalcemia. So low calcium. Okay. Okay, now most importantly, that you have this, right? You have this is a neoplasm parafollicular C cell which secretes calcitonin, so prophylactic thyroidectomy is required in patients with men 2A. So let me write it down. I don't know where it is in the book, but if you see a patient with a RET mutation, prophylactic thyroidectomy is required, because eventually they will go into medullary thyroid carcinoma. So before, I guess they mentioned it here, before they even go in there, you just got to remove the thyroid. Simple. Okay. And then you have pheochromocytoma, which secretes catecholamines, right? And a mutation. MEN2 has a mutation in RET, same as MEN2A, B have RET. So why don't we say it this way? MEN1 is going to be mutation in MEN1, same. MEN2 mutation in RET. So all you got to remember in the whole page is RET, because other than MEN1 is MEN1 right there, right? Is only one difference is RET, which is here. Simple. Okay, just remember RET, autosomal dominant RET for 2, because both are 2. Now what we want to know, what is RET now? We got to understand what is RET. Okay, for RET, let's read first here. Mutation in RET. RET is a proto-oncogene which codes for receptor tyrosine kinase on chromosome 10. Okay, so when you have a proto-oncogene which codes for receptor, and you have a mutation here, and this mutation is a gain of function mutation, that's very high yield. It's a gain, because you will see other RET mutations which are not gain of function, but here specifically we're talking about gain of function, meaning you have increased RET, meaning increased tyrosine kinase. When you have increased tyrosine kinase, guess what's going to happen? Well, you are going into unregulated growth and differentiation. That is why you are going to develop all these medullary carcinomas. Okay. Then you have, what else you can have in this? Okay, let's go on to the last one here, and that is our MEN2B. MEN2B, medullary thyroid carcinoma, which is from top. So I'm just going to do the same color here. Pheochromocytoma from top. The only new thing here is going to be your physical findings. Mucosal neuromas. Look at picture A. What are these neuromas? Well, these are oral or intestinal ganglioneuromatosis. Okay. These are benign growth. What are they basically? They are benign. First of all, they're benign growths of nerve tissue. Okay, so they are benign growths of nerve tissue. Simple. So all these are that you see as a protrusion on the tongue. Let me see this diagram. Look at this one. So these are just nerve tissues. They are just nerve tissues, and they look fleshy. So let's just define this. They're gonna on the description they will say, okay, this flesh-colored nodules. So let's just write it: flesh-colored nodules anywhere along oral and intestinal area. Okay, so let's just put it on lips or on tongue or anywhere in GI. Flesh-colored nodules. Okay, important. And then you have, so you got mucosal neuromas. The next thing we have with MEN2 is going to be another physical finding. That's your marfanoid habitus. Marfanoid habitus. Now, we have to differentiate marfanoid habitus, because when you see marfanoid habitus, you might think of Marfan syndrome, right? Marfan's. So how do we differentiate? So let's talk about marfanoid habitus. Marfanoid habitus, you will have a tall, disappropriate arms, 2 legs ratio, joint laxity, right? But all of this is going to be present without, which you will just see with Marfan, without ectopia lentis, or aortic involvement. So in Marfan, let's just put it this way. With Marfan, you will see all of this. On top of it, you will see ectopia lentis and aortic involvement. But with marfanoid habitus, which is not Marfan syndrome, All you are seeing is the uh, tall with an disproportionate arms to legs ratio, joint laxity, and all the other findings of uh, just the habitus, not the Marfan syndrome. Okay, hope that makes sense. Uh, and that is going to be all. Let's just review the whole part and move on. So here we have the first thing: men are dominant, autosomal dominant disease. Men1 mutation, men2 ret mutation. No matter 2A, no matter 2B, both are ret mutation. Men2A, all are medullary. All are medullary. Let's put it this way. Let's put it easy way. Men2, no matter you are looking at A or B, all are medullary. So the common feature that they have together as men2, meaning 2 medullary tumors. 2 for 2, right? What are they? They are going to be medullary thyroid carcinoma and adrenal medulla, which is pheochromocytoma, right? Both of them have that. Now with an A, you're just looking at the parathyroid coming from top. B, all you're looking at the B physical symptoms. B means 2 physical symptoms are going to be mucosal neuromas and morphonoid habitus. And that is going to be all. Let's move on to the next part. Here we have pancreatic islet cell tumor. And these are going to be your insulinoma. Insulinoma is a tumor of pancreatic beta cell, which leads to overproduction of insulin, which leads to hypoglycemia, right? May see Whipple triad, which is high yield. What is a Whipple triad? Low blood glucose, plus you have symptoms of hypoglycemia, which are lethargy, syncope, diplopia, and resolution of symptoms after normalization of plasma glucose levels. 3 things. That's why called triad. Symptomatic patients have decreased blood glucose and increase in C peptide levels. Got to know this. You would have increase in C peptide versus exogenous glucose. Remember, insulin comes along. When insulin gets out of the pancreatic beta cells, it comes as insulin plus C peptide. But if you're giving someone from outside, exogenously you're giving insulin, you're not giving C peptide with it, right? You're just giving insulin. So C peptide will not be raised. But if it is endogenously insulin is coming out, it's going to come out as 2 parts, insulin plus C peptide. And in fact, the C peptide has a longer half-life. And that is why we check the C peptide levels if we are thinking about insulinoma or anything else to see how the endogenous production of insulin is working. Okay, so increase in C peptide, 10% of the cases associated with men1. And we did talk about how insulilomas or any of these diseases, pancreatic endocrine tumors, insulinoma right here, right? Any of them, any ZE syndrome, lipoma, glucagonoma, anything. You think about men1. All right. So here's the same thing. Men1. It is associated. 10% of the cases are associated with men1. Treatment is surgical resection. Okay, let's review this and move on to the insulinoma. Just think about Whipple triad, low blood glucose levels and their symptoms and resolution after you have normalized the glucose level. Although look at the name, Whipple triad. Nobody, if you don't know Whipple triad, the word is so diffusing. Like you think Whipple, what is gonna be? It's simple. Got to just remember Whipple, low glucose. Symptoms of low glucose. You give the glucose, you're good to go. The symptoms resolve. The Whipple triad, simple. Okay, with that, moving on to the next one. Now we got the glucagonoma. Glucagonoma is a tumor of the pancreatic alpha cells because alpha cells secrete glucagon and beta cells secrete insulin. So uh, that's pretty well understood. Then you have the overproduction of glucagon, right? Glucagonoma produces glucagon. Simple. Presents with 6Ds, high yield 6Ds, dermatitis, which is necrolytic migratory erythema, diabetes, hyperglycemia. Okay. And again, why is it causing, now you ask, hey, why glucagon is causing diabetes? Because if you remember, glucagon is one of the counter-regulatory hormones. All the counter-regulatory hormone, all of their job is to put glucose back into the serum, right? When they put the glucose in the serum, you're causing hyperglycemia. What is hyperglycemia? Isn't it diabetes? It is. Okay. And that's why it's mentioned here. It also leads to DVT, declining weight, depression, diarrhea. Okay. Let's talk about a little bit about dermatitis with the glucagonoma. Glucagonoma, you had dermatitis, which is necrolytic migratory erythema. This is going to be seen as blistering erythematous plaques with central clearing. Okay, so let's just have a central clearing, but it's going to be blistering erythematous plaques. Erythematous plaques. Okay, with that, where are they going to mention this? So let's actually dive a little deep into dermatitis here. Dermatitis with the increased glucagon is going to be, first of all, as they mentioned, necrolytic migratory erythema. Erythematous plaques or papules will be present on will come on face, extremities, or the perineum groin area. Okay. Lesions will enlarge. So these lesions will enlarge and coalesce, leaving a central innervated, like a depressed area with peripheral blistering and scaling. And this whole thing, dermatitis, the same sort of dermatitis, if you go back in your book, you will see zinc deficiency. It is also seen with zinc deficiency. It's going to be in your biochem section. But for sure with zinc, you are going to have the zinc problems, zinc findings. Okay. But this is important of dermatitis, glucagonoma, dermatitis. The mind doesn't go there, but you got to push the mind. Okay, glucagonoma, something important. Dermatitis, diabetes for sure. DVT, declining weight because you are trying to put everything in. You are trying to increase lipolysis, increase proteolysis. You're trying to put the whole thing into the bloodstream. For sure, you're going to go into weight loss, declining weight there, depression, diarrhea. Okay. And that is going to be pretty much all. One important thing is if you were to decrease, so this is glucagonoma where you're increasing glucagon, right? Just another story. If you have low glucagon, which is not this one, but if you have low glucagon, one of the things that you have to know that with low glucagon, you are going to go into hypoglycemia. Okay. So let's review it quickly. We have glucagonoma, meaning overproduction of glucagon, 6Ds, dermatitis, high yield, diabetes, DVT, declining weight, depression, diarrhea. Treatment is octreotide surgical resection. But in the opposite case, if you have low glucagon, you're not going into hyperglycemia, but you are going to go into hypoglycemia. So with higher glucagon, hyper; with low glucagon, hypoglycemia. With that, let's move on to the next part, which is somatostatinoma. Okay, somatostatinoma, which is a tumor of pancreatic gamma cells. Overproduction of my bad, delta. Okay. tumor of pancreatic delta cells, which is the overproduction of somatostatin, which leads to decreased secretion of secretin, CCK, which is cholecystokinin, glucagon, insulin, gastrin, um, gastric inhibitory peptide, GIP. So all you gotta, I mean, who's gonna remember all of this, right? I don't think. Well, if you can remember, great. You know, you're great. You're genius. But simple way that you can understand this is, okay. Somatostatin is the blanket of all hormones. Blanket of all hormones. So when it is blanket of all hormones, no matter what hormone you have, you think about secretin is gone, CCK gone, glucagon gone, insulin gone, GIP gone, everything is just out because it's a blanket. So somatostatin, statin means inhibition of all hormones here, okay, may present with diabetes, right? Glucose intolerance, because you are inhibiting insulin here. So diabetes, glucose intolerance, steatorrhea, gallstones, and achlorhydria. Okay. Treatment is going to be surgical resection, or you can give somatostatin analog, for example, octreotide, for symptomatic control. Okay. So that is going to be all for this somatostatinoma. Okay. Then you have, so let's just review it first. Somatostatinoma, simple overproduction of somatostatin, which is a blanket of all GI hormones. It's going to inhibit all GI hormones, secretin, CCK, glucagon, insulin, and GIP. It can present with glucose intolerance, diabetes, steatorrhea, gallstones, achlorhydria. Treatment is going to be, you have to either surgically resect it or give an analog from outside, which is octreotide, for symptomatic control. Moving on with the next thing is going to be the carcinoid tumor. Carcinoid tumor arise from neuroendocrine cells. High yield, they arise from neuroendocrine cells, most commonly in the intestine or lungs. Neuroendocrine cell, they secrete 5-HT, which is serotonin, which undergoes hepatic first-pass metabolism and enzyme breakdown by MAO in the lungs. Okay, so if it is going into extensive first-pass metabolism, this serotonin, if it goes to the liver, it's going to get destroyed by all MAOs, right? And if serotonin reaches the systemic circulation after liver metastasis, carcinoid tumor may present with carcinoid syndrome, which is episodic flushing, diarrhea, wheezing, right-sided valvular heart disease, which is tricuspid regurg, pulmonary stenosis, and increased urinary 5-HIAA. Excess 5-HT production depletes tryptophan stores, leading to niacin deficiency, which is pellagra. Okay, with all of this, let's take a look at now. I guess we have to go back to the biochem. So what is biochem for all of this tryptophan and all that? So if you know you have a serotonin metabolism, how is serotonin metabolized? First of all, you have tryptophan. Synthesis of serotonin is like this. You have tryptophan, and then that tryptophan becomes your 5-HTP, which is your 5-hydroxytryptophan. Simple. 5-hydroxytryptophan by the enzyme, which is sort of I don't know if it's a low yield, high yield, but biochem just know the enzymes. Okay. Tryptophan hydroxylase. Okay. 5-HTP, which is 5-hydroxytryptophan, forms 5-HT, which is tryptophan, which is serotonin, my bad, right? And this serotonin then gets into metabolism by an enzyme, which is MAO. MAO is only present here in the liver plus lungs. Okay. And when you metabolize your serotonin, what are you forming? You are going to form 5-HIAA. Well, actually, the first thing you're going to form is 5 hydroxy indole acetyl dehydrogenase. And then that leads to when the aldehyde dehydrogenase exon, it is going to form 5 hydroxy indole acetic acid. So what is it? 5-HIAA, hydroxyinidole acetic acid. This, now, if you have a lot of, so let's, now with that, with all this in background, let's take a look here now. We have increase with carcinoid tumor, which essentially is a neuroendocrine tumor, which is secreting a lot of serotonin, that a lot of serotonin will get degraded, right? And when you degrade serotonin, you're going to get a lot of metabolite in the urine. And you, because it's making a lot of serotonin, you're going to deplete its precursor, which is tryptophan right here. So it's going to decrease tryptophan. When you decrease tryptophan is also necessary for niacin. So it's going to cause niacin deficiency, pellagra. Okay. With that, now let's look at the histology. Histology, we have rosettes. Picture A, you can see some rosettes. Chromogranin A and synaptophysin A, synaptophysin positive. So what are these rosettes? Let's talk about these first. Histology. So these are, I don't know if you can see in the picture, but they are properly arranged cells in a circular manner. So they are the islands, sheets of cells, of uniform small cells, eosinophilic, which means pink. They're pink, right? So eosinophilic cytoplasm, oval to round nuclei with peripheral palisading. High yield, these nuclei will look like salt and pepper chromatin. Okay. It's like salt, and within the nuclei, you will have some granules, salt like salt and pepper chromatin. Okay. But what do we need to know? These are going to be rosettes. They are going to look like rosettes, which are just uniform peripheral palisading cells with pink cells, eosinophilic cells. Okay, with that, let's look at the diagnosis. How do you diagnose it? Again, you got to look at 24 hours urine excretion of your 5-HAA, which is your metabolite of the serotonin. Okay, octreotide scintigraphy will lead to tumor localization and staging. Okay, then you have the treatment. For the treatment purposes, you have surgical resection, somatostatin analog. Again, the reason behind we giving somatostatin analog, as we said, somatostatin inhibits all hormones. So if you give somatostatin, it might inhibit it. Octreotide or tryptophan hydroxylase inhibitors, or you give tryptophan hydroxylase, this first enzyme. You want to inhibit this enzyme so you don't even make serotonin. Okay, which is tryptophan hydroxylase inhibitors. Example, the drug is telotrestat. Okay, for symptomatic control, because if you inhibit this, you're not making serotonin. You don't have symptoms of serotonin because you're not making it. Okay, there are rule of thirds. What are rule of thirds? So let's change color here. 1/3 would metastasize, 1/3 would present with secondary malignancy, and 1/3 are multiple. Okay. With that, let's talk about little extra things, which we did mention in the first place here. Okay, so now we got the whole idea about carcinoid making serotonin. Now let's talk about where they are going to be present, right? So most commonly, they said here, they're most common present in either the intestine, which is your GI, or they're going to be in lungs, right? So if the carcinoma, let's talk about GI and lungs. So let's just zoom in here. I actually don't have space, so let's just talk it here. Okay. So if you're talking about a GI, for example, carcinoid tumor in GI, most common location is going to be within the GI. The most common location is the ileal tumor. Ileal tumor. Okay. So in the ileum, we have this carcinoid tumor, most common. So from the ileum, it's going to secrete. So let's say this is GI. From the ileum, it's going to secrete the 5-HT, which is serotonin. That 5-HT will go to the liver, right? It's going to through all the portal circulation. It's going to go where? To the well, I think this is very macro. I gotta write in a smaller way so we can make sense. So from here, the blood, it's going to go to the liver. Let's just draw liver here. Okay. In the liver, from portal circulation is going to go to liver, but in liver we have an enzyme. So in liver it gets metabolized by the enzyme MAOs, right? MAO. They're like, yeah, we got you, man. We're going to stop you right here. No more symptoms. So all you're getting is metabolism of your 5-HT into 5-HIAAs, right? So you have, important point is, so you're not going to see no or not much sign symptoms because it didn't even go outside. It wasn't blood. Didn't cause any problem there, right? That's one thing. Now the problem arises when the tumor from the GI, carcinoid tumor from the GI, send metastasis to the liver. Now this carcinoid tumor, which was present in the GI, now has the mets within the liver. And now what they're going to do within the liver, they're going to send out into the blood serotonin. And now when they send out into the blood the serotonin from the blood, the serotonin, okay, if you recall the blood supply from the liver, you're going into hepatic vein, and from hepatic vein, you are going to go into a couple things. First of all, you have to go into IVC, and from IVC or hepatic veins, you are also going to send these the serotonin within the systemic into other smaller arteries due to systemic shunts. Then it's going to give you symptoms, and also from IVC, inferior vena cava, it is going into carcinoma. It's going to go into the right heart, and then the lungs. Right heart, there is something called carcinoid right heart disease, and I will talk about when it goes into the right heart, it's going to cause carcinoid right heart disease, and I will talk about that one. But when it goes to the lungs now, fortunately in lungs, let's just draw lungs here. In lungs, what we have, this is more like kidney. I'm bad at drawing, but something like this. Okay, in lungs we have, again, our good friend MAOs. And when the serotonin reaches, so let me just put serotonin here, 5-HT reaches lungs, it is then converted by MAOs into an inactive metabolite, which is 5-HIAA within the lungs. Okay. So, and then this goes into the urine, and we see 5-HIAA in the urine. We say, okay, we have a problem of serotonin metabolism. Now, Now let's go back and understand the whole thing that I am trying to tell you. We said the most common location is in the GI or in the lungs. So if now think about it. If you have a problem here in the GI, which is most common in the ileum, it could be in the appendix, it could be in the rectum. All three. In the intestine, what are we thinking about? What intestinal areas are we looking at? Ileal is the most common. Again, ileum most common. Appendix could be one of it. If we are going, I don't know if you know appendix. Appendix is one of the things in appendix is these carcinoid cells being there. Appendix. Okay. The third thing is going to be a rectum. But all of them, what they are going to do, let's just get this into, is this? Yeah. Okay. So we have it in the GI. From the GI, when it sends you the portal circulation into the liver. Now in the liver, fortunately, we have these MAOs. These MAOs are going to destroy that serotonin. So we are not going to see any symptoms when we are talking about specific GI carcinoid tumor. No symptoms. But if, again, we have a GI tumor that goes and send the mets to the liver, now the tumor is in the liver now because the mets are here in the liver. Now they are going to send that serotonin outside into the hepatic vein and do IVC, and they're going to cause sinus symptoms. What are sinus symptoms? For example, they are going to cause flushing, another carcinoid symptom, which we'll talk about in a bit. But sinus symptoms are there, okay? And they're not going to stop there. They go from here. They also cause right heart carcinoid, right heart, carcinoid, where is it? Carcinoid, yeah, right here. Carcinoid right heart disease, okay, from IVC. And then when it goes eventually into the lungs, then it gets destroyed and nothing goes out. But here, now, what is the summary here? Summary is that if you have a problem in GI, specific only GI, not METs, then you don't have any signs and symptoms. But if you have the METs to the liver, basically the primary side is still GI, but the METs are there, then you will see signs and symptoms. And you will also see signs and symptoms when you are talking about specifically lungs. Lungs, no matter what, because you have the symptoms of it over there, okay? Now let's talk about symptoms. Here are the symptoms. Carcinoid syndrome. So first, I guess with that, let's just quickly read this so you understand what I just talked about. So serotonin, which undergoes hepatic first pass metabolism, essentially saying, you as soon as you come from GI, you're going to go into first pass metabolism, which is through liver. From GI, goes to liver, gets destroyed. And enzyme breakdown by the MAOs in the lungs as well. Then you have serotonin reaches systemic circulation, that is going to give the signs and symptoms, right? What are they? After liver metastasis or carcinoid tumor may be present with carcinoid syndrome, which is symptoms are episodic flushing, diarrhea, important episodic flushing, diarrhea, wheezing, again, heart is also there, right-sided valvular heart disease, which is your tricuspid regurg, pulmonic stenosis. Again, on the right side, you have only two valves. You have the tricuspid, and tricuspid regurg is going to be there. But again, you can also cause pulmonic stenosis. So one is regurg, one is stenosis. With that, let's actually take a look at right heart here. Right heart, carcinoid heart disease is going to, and let's zoom in. Carcinoid heart disease is the right heart valvular fibrosis, right heart valve fibrosis. And why is fibrosis with the carcinoid? One thing that you got to know is a simple physiological factor. Okay, this is good. Okay. Simple physiological factor of serotonin. Serotonin is that serotonin stimulates a couple things. It stimulates fibroblast growth factors. Fibroblast growth factor, one thing. Second thing, it stimulates its fibrinogenesis. fibrinogenesis. With that, let's take a look at now when it goes to the heart, when it goes to the right side of the heart, because it can go to the left because the lungs will metabolize it, so it only can affect the right side. Okay, so when it goes to the right side of the heart, it's going to cause valve fibrosis. Why? Because due to increase in collagen, by increasing collagen, and this causes two things. When you increase the collagen, causing fibrosis, it's going to cause tricuspid valve regurg and pulmonic valve stenosis. Okay, and the second thing which they haven't mentioned is it is also going to cause endocardial thickening. So just remember, the whole right side is just going to be thickened. When you thicken the tricuspid valve, you're going to go into regurgitation. When you thicken the pulmonic valve, you're going to go into stenosis. But think about this as a hallmark, which is fibrosis by increasing collagen due to the fact that you have a lot of serotonin, which is the normal job of serotonin is the fibroelastin, causing increase in collagen. Okay. Let's talk about some more symptoms here. Some more symptoms. Well, let me erase these first. Some more symptoms and that you will see are going to be in your skin. You're going to have telangiectasias, telangiectasias, cyanosis in skin, wheezing. Why is it wheezing there? Because it causes serotonin causes bronchospasm. Bronchoconstriction causing bronchospasm leading to wheezing. Okay, watery diarrhea, cramping, recurrent diarrhea or watery diarrhea. Where is diarrhea here? Diarrhea. Which side of diarrhea are we looking for? It's going to be cramping, watery diarrhea. Again, you have increased serotonin. That's why. Okay. Again, on the right side, right heart side, you will see fibrous plaques, even fibrosis, fibrous plaques. Okay, with that, I think pretty much we did talk about most of the things. Yeah. Okay, now let's look at these are all the symptoms of carcinoid syndrome, which is essentially increase in serotonin. Now, one thing for going to be for the diagnosing, you have high yield is this again, increase in 5-HIAA. It is used for screening purposes. So this guy, 5-HIAA, is for screening purposes. Now, to diagnose it, you have to go for CT scan or MRI. Wherever the locations are, where do you think it's going to be in? It's going to be in either the abdomen or it could be in the rectum as well. So just to abdomen, pelvis, to localize tumor. We are doing CT MRI to localize tumor to a specific organ. And highest yield is going to be your where are the markers here? Neuroendocrine markers, chromogranin A, synaptophysin positive. Okay, with that, I think we did a pretty good job here. Explained the whole thing. Okay, nice. So what we are going to do is quickly look at it and move on to next. Serotonin, carcinoid syndrome. Just think about carcinoid as increased serotonin. It can go into intestine or lung. Intestine means GI. GI means the most common ileum. Then you have appendix and rectum as other causes. But if it is in GI specific, it is within GI, it's not going to cause signs and symptoms. But if it sends the mess to the liver, it's going to cause signs and symptoms. Because from the liver, it's just going to go out. A liver will destroy it by MAOs or their first pass metabolism. And the lungs will also destroy it by their MAOs. the symptoms are high yield, episodic flushing, diarrhea, watery diarrhea, recurrent watery diarrhea, patient, yeah, wheezing, bronchospasm, right heart valvular disease due to fibrosis, causes TR, pulmonic stenosis, high yield increase in 5-HIA in the urine, and you have excess production, which will deplete tryptophan, leading to niacin deficiency, chromogranin A positive, synaptophysin positive, and you can resect it. You can give analog like octreotide, or you can give the tryptophan hydroxylase inhibitor, which would inhibit its formation, serotonin formation or synthesis. With that, pretty much we are good. 1/3 would metastasize, 1/3 would present with secondary, and 1/3 are multiple. All right, that is all. Let's move on to the next part. Here we have Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is the constellation of symptoms resulting in acid hypersecretion from the gastrin secreting tumor. Again, as they mentioned, gastrin, so just remember that the Zollinger-Ellison syndrome is in fact hypersecretion, acid hypersecretion from gastrin secreting tumor, gastrinomas in duodenum, most common, or the pancreas. So two areas, either could be duodenum, either could be pancreas. Okay, and then it leads to single or multiple recurrent ulcers in the high yield. Okay, if you have anything beyond duodenal bulb, if you have single or multiple, any ulcer beyond duodenal bulb, in the duodenum, most commonly they can say duodenum, okay, or jejunum, then you have often refractory to the proton pump inhibitors. You think about ZES now, okay, that's very high yield, with resulting malabsorption because of acid inactivation of the pancreatic enzyme secreted into the small bowel. Now this guy is going to present with abdominal pain, heartburn, diarrhea, steatorrhea, weight loss. Positive secreting stimulation test, which increases gastrin levels after secretin administration, which normally inhibits gastrin release. So normally secretin would inhibit gastrin release, but here in Zollinger-Ellison syndrome, where basically you have a lot of, what is Zollinger-Ellison syndrome again? It's just with the names, just always, go with what's the basic thing here. The basic thing again here, you have increased gastrin. Simple. Increase gastrin, or you can say gastrinoma, because everything was noma, right? Like, so gastrinoma, meaning increased gastrin. When you have increased gastrin, there's something secretin which normally would inhibit the gastrin level, but now when you give secretin, there's increase in gastrin levels. Wow. And that is just going to be a positive, that's called positive secretin test. Okay, then you have this chromogranin A positive, okay, maybe associated with MEN1. We talked about MEN1 being associated with all of these pancreatic endocrine tumors. Okay. With this, let's talk about a little bit about pathophysiology behind this gastrin. So when you think about gastrin, so let's just put it here. Gastrin, so normally gastrin causes what? Gastrin goes into the parietal cells, right? And that parietal cells leads to secretion of your HCl, right? So now think about it. When you have a lot of gastrin, you are, first of all, that a lot of gastrin is going to go to your parietal cells, is going to put a lot of acid, and that is the reason that you will have ulcers beyond the duodenal bulb or in the jejunum, right? And it's going to be refractory to PPIs because it's here you have a problem with, you have increase in gastrin due to a tumor, nothing else. So you can't stop a tumor by a drug, so you can't it's refractory. That high HCl is going to be refractory to PPIs. And because you're putting in a lot of that HCl, hydrochloric acid, it's going to result in malabsorption because this acid would inactivate the pancreatic enzymes high yield. This acid inhibits pancreatic enzymes, one thing, right? So with this acid is going to, first of all, it's going to stay within the stomach and it's going to go down. Wherever it's going to go down, you have ulceration of that. You're inhibiting the pancreatic enzymes. Third thing, it can cause heartburns. A lot of acid heartburns is going to be there, right? With diarrhea, steatorrhea, when you don't have pancreatic enzymes, you can't reabsorb your fat. So all those fats are going to go out, and you are going to have steatorrhea. Okay, weight loss is also there because you're not absorbing things, and that is why you have weight loss. But that's not important here. What is important is going to be your malabsorption due to pancreatic enzyme inhibition, steatorrhea with recurrent ulcer, which is the highest yield beyond the duodenum or jejunum. And that is going to be what we have. And you can test this out by giving a secretin stimulation test. Okay. The one thing they will mention is when they do endoscopy, you will see enlargement of the gastric enlargement or hyperplasia of these parietal cells. So endoscopy will show hyperplasia of parietal cells in the stomach. Now, why is that? Because again, you go back, you have increased gastrin that is stimulating your parietal cell, which is secreting HCl. So you are stimulating your parietal cells so much that they are going into hyperplasia, and you will see that on endoscopy. Okay, simple as that. Moving on. Okay, let's just quickly review this. ZES, think about gastrin, secreting tumor, gastronoma. Okay, in duodenum is most common. So location-wise, duodenum is the most common site, or even the pancreas. It's going to cause ulcer beyond duodenal bulb or jejunum, which normally there's no ulcer in jejunum. By the time it goes in jejunum or duodenum, there's no acid. Okay, but here, because you're producing acid so much that it's just going to travel down and down, duodenum and jejunum. Okay, would resulting in malabsorption because that acid will inhibit pancreatic enzymes. You need that for fat absorption, so steatorrhea, diarrhea. Okay, with that because a lot of acid is there, heartburns, abdominal pain. Secreting stimulation test would normally inhibit these gastrin levels, but now this is a tumor, so it's not going to inhibit it. So that's why you can have increase in gastrin levels. It is associated with MEN1. With that, let's move on to the next. Okay, great. Pharmacology. Okay, guys, now I'm seeing your comments. Good to see you all here. Okay. Let's go with now pharma. It's going to be high yield. Pharma is very high yield. Specifically, this diabetes meds. So let's dive into this. Okay, the first thing we are going to talk about is called diabetes mellitus therapy, high yield. So what do we have here? So let's read first. All patients with diabetes should receive education on diet. So first thing, diet. Second thing, exercise. Third thing is blood glucose monitoring and complication management. Okay, treatment differs based on type of diabetes and glycemic control. For sure. So we have type 1 diabetes. For them, we need insulin. For type 2 diabetes, we need oral agents like metformin, which is the first line of drug, or non-insulin injectables, or insulin replacement could be there. Weight loss, particularly helpful in lowering blood glucose levels. The third sort of diabetes is gestational diabetes, which is you can give insulin replacement if nutritional therapy and exercise alone fails. Okay. With that, let's take a look at some insulins. You have a regular insulin, which is a short acting, is preferred for DKA IV high yield. For DKA, we give IV because why we give IV a regular short acting insulin, that it has a rapid action, and we'll talk about that. But here, rapid action, and through rapid action, we can have DKA, in which we have more than 300 glucose. We can get that fixed. In DKA, if you recall, we have absolute insulin deficiency. So we need insulin from outside. That's why we give IV, that it goes right away and causes this action. We don't have to wait 30 minutes or 20 minutes for it to start working. We give IV. But in on the other ways, for example, this regular is so short acting that it is normally given as a pre-meal insulin. Wait here. So normally, regular, which is a short acting insulin, is given as a pre-meal, meaning before you have a meal, you inject the insulin like 30 minutes before. Okay. But that pre-meal is given subcutaneous. And that is why you have a 30 minutes of break time. Okay. Show time starts when? After 30 minutes. But we don't need a show time when we are going in DK, do we? We want right away stat, IV. Get right away. Start work right away. That's what we're getting paid for. But okay. Moving on with hyperkalemia. With glucose to prevent concomitant hypoglycemia and stress hyperglycemia. Okay, so again, what did we talk about the whole thing? We said regular short-acting insulin is preferred for DKA, is preferred for hyperkalemia. With glucose to prevent concomitant hypoglycemia, what their meaning is, when you give insulin to for hyperkalemia, you want to also use glucose because you don't want to go into hypoglycemia. And this is simple. We'll talk about that. And stress hyperglycemia as well. Okay, with that, let's take a look at so the way we're going to do this is first we're going to read it from here. And then we are going to look at this picture. Okay, so now let's talk about the first thing we have is the insulin preparation. Insulin is, we have a couple of preparation for insulin. For example, we have the rapid acting insulin, which is the no lag. No lag is Lispro, Aspart. Names are high yield. Okay, no lag. And they what are they? Like, for example, short acting, regular, rapid acting, high yield. So no lag is Lispro, Aspart, and Glucagonoma. And this is the picture of it. Look at the peak. So it starts right away. Rapid acting, meaning it acts right away. Plasma insulin level goes right away up high to the peak and then draws back right away. Time, look at the time. So it has a peak in 1 hour. So if you think about this, peak is about in 1 hour. Okay. And then you have this short acting. So just remember, forget the peak, forget everything. Remember rapid acting, no lag, know the names, Lispro, Aspart, Glucagonoma. And because it's a rapid acting, so just think about it. It's the first one. It goes up higher and gets back right away, very quick. Okay. Then you have the short acting. Short acting is your regular insulin. Okay. Regular insulin. Now this regular insulin, insulin is going to be where here. Okay. In this regular insulin, you can see that it has it starts working after 30 minutes. So let me just actually, you don't have to memorize it. So I'm just going to mention all of this part so you have something in the mind. So for the regular insulin, just always what you're going to think of is going to be, it's going to start working within 30 minutes of administration. Okay. 30 minutes of administration is going to start working. And why is that? Because it is it is dimer and hexamer formation, which takes dimer and hexamer formation, which takes time to dissociate after the injection and causes the absorption delay. Okay. Rapid acting are used to overcome this. So because there is a 30 minutes delay, so you can use these rapid actings, which is lisinopril, glucagonoma, and they can be used because these are monomers, and they don't need the time to get absorbed into the tissues. So these are monomers, and they get absorbed right after the administration. So what do we learn from this in this just dimension? So this one is monomer, this one is, let's say, dimer, and it needs time for absorption. How much time? Absorption needs 30 minutes. And this right away. Okay, so because it has an action of right away, one high yield point is that these lisinopril, glucagonoma, which are rapid acting, they resemble pre-meal related insulin surge. So what do they resemble? Pre-meal. Let me write it down here. Pre-meal. And this is a high yield point that so physiologically, if you want to have some insulin, which normally, when you want to eat a pre-meal, you will have insulin surge. So that is going to resemble by your rapid acting. Okay, let me put it this way. Pre-meal administration of this rapid acting will give you increased insulin secretion post meal. Like after you're done with, you'll have increase in insulin within the bloodstream. So this rapid is going to replicate like pre-meal related insulin surge. Why am I mentioning that? Because first of all, what we do is we give patient, so this is normally we give patient pre-meal. We tell them, hey, when you want to have a meal, inject this insulin. This is going to be your lisinopril, glucagonoma. But we will also want to put the patient on something which is going to be the basal insulin, which is going to be your glargine right here. So glargine, this guy replicates basal insulin secretion. So you have something called basal insulin, and you have something called insulin that comes after a meal, normal physiological way. Basal is always there, and this post meal you have insulin surge. So that surge we can give from outside, which is your rapid acting, and to have the patient on a basal insulin levels, which will not mess up the glucose levels, like not going to cause hypoglycemia. These are going to be your glargine. Okay. And why is it basal? Now the question is why this guy is basal, meaning why when we inject it, why doesn't it just go all the way? The whole content just goes into the bloodstream. Why does it stop? Because what we have it precipitates within the subcutaneous tissues. So it precipitates within your subcutaneous tissue and slowly absorbs within the bloodstream. Slow absorption into bloodstream. And that slow absorption gives us that basal insulin. Okay. Some other things you can think of, which is just an extra thinking. You don't have to memorize this part, but it precipitates within the subcutaneous tissue, but also you have to think it precipitates because it has a pH of 4. It has a pH of 4 and forms microprecipitates. So this glargine forms microprecipitates at the site of subcutaneous injection, and then slowly those small precipitates go into the bloodstream, cause the basal insulin levels. The important point is just know which ones are what. So glargine is the basal, while the rapid ones are pre-meal insulins. With that, let's move on to the next part. And that is going to be, so we talked about a short-acting regular, difference between these two, and glargine as well. The next is intermediate acting, which is NPH. Now, intermediate acting NPH, it has, let's look at NPH first here. NPH. Now, for the NPH, it contains protamine and zinc. It contains protamine plus zinc, which prolongs the duration of action by delaying its absorption. Okay, this protamine and zinc will prolong its duration of action and its about duration of absorption and its action, duration of action. With that, let's move on to the next thing, which is called long-acting, which is D-dimer and glargine. We talked about glargine, where the D-dimer is going to have, let's talk about D-dimer now, D-dimer right here. So D-dimer, we have, it contains fatty acids. So it contains, so NPH containing protamine plus zinc, right? So this guy contains fatty acid, which binds to lysine amino acids on the insulin molecule. This fatty acid side chain allows D-dimer to bind albumin and slowly dissociate afterwards. So what do we need to know? We need to know that D-dimer binds albumin because of its structure. It binds albumin and slowly dissociate afterwards. Binding of albumin causes its slow dissociation and a long acting. Okay, now we have a very long acting, and that is degludec. Now degludec is where is degludec? If you look at this, this is very long acting degludec, but again it goes back, right? So degludec, it contains hexo decannabidiolic acid residues, which polymer formation at injection site and slow uptake. Okay, so whatever it does, what it does is basically it forms the polymers at the site of injection. Polymers at site of injection, and that is why it slows uptake. So why did I mention all of this? So I am mentioning all of this because they are details for insulin. Insulin is a high yield topic. So you got to know that these things are somehow, they are all insulin, but the problem is we are trying by their mechanism of actions is the same, but we are trying to delay their absorption, to delay their duration of action by delaying the absorption. Some of them are just forming precipitates, some are monomers, some are dimers, but somehow we are getting our things done by putting some pharmacological additions into our insulin. Now, one more thing that you would have to know is which ones are insulin analogs. Insulin analogs. So insulin analogs, your regular and NPH are your insulin analogs. What do I mean by that? They're human DNA recombinant insulins without modification in their amino acid sequence. So they're human DNA recombinant insulins, known as insulin analogs. Okay, and which are to the regular and NPH. With that, let's take a look at the mechanism now. Easy part. Now, the mechanism, you have insulin binds its receptor. What receptor binds? The tyrosine kinase, right? When this insulin binds this tyrosine kinase activity, it's going to have its further effects on the organs. So in the liver, you're causing increased glucose storage as glycogen. In the muscle, you're going to cause increase in glycogen and protein synthesis. In the fat, increase in fat storage, which is triglyceride storage. And the cell membrane, high yield, is increase in potassium uptake. High yield potassium uptake. You give